First, talking about the anatomy of pulp cavity. So, what is a pulp cavity? Your complete soft tissue, your complete nerves and vessels is housed in the center of the tooth, surrounded by your dentin is called as a pulp cavity. So, your pulp cavity is of two parts. The one which is present in your coronal portion of the tooth, that is your crown portion, is called as a pulp chamber. The one which is present in your radicular portion is called as a root canal. So, your pulp chamber and root canal together is called as a root canal system or pulp cavity. Understood? So pulp chamber is the one which occurs in your coronal portion. Okay, there will be some accentuation or exaggeration of your chamber exactly under the cusp tip. They are called as a pulp horn. So the first step when you do an access cavity, you will gain access into this pulp chamber only. After you completely enter the pulp chamber, so any pulp chamber will have six surfaces. There will be a roof, there will be a floor, there will be four surfaces: buccal, lingual, mesial, and distal. Always remember, you have to completely de-roof. You have to completely remove the roof, the topper layer of pulp chamber. Then only you will be able to visualize the floor. Okay. On the floor, you will have something called as a root canal orifices. So when you are able to see this orifice, you will be able to put the file into the orifice, and this will enter into the root canal. Root canal is nothing but a portion of pulp cavity in the radicular portion. Okay. You need to know, you need to have a clarity about individual terms what they are telling. Understood? So pulp chamber in the coronal portion, root canal in the radicular portion. So combined, it is called as a pulp cavity. So in pulp chamber, you have a roof, floor, and four surface. You will completely gain access into the pulp chamber and de-roof the chamber, and you will enter the floor. And always make sure you are not supposed to cut the floor. The floor is very important. Once you are cutting the floor, you will enter into the furcation area. And after that, any root canal will exit the tooth apex through an opening that is called as a apical foramen. So in this apical foramen, your blood vessels will enter and exit the root canal. Okay, so now in this root canal, this is a primary canal, the main blood supply. Apart from that, there will be, you all know a pulp cavity is a three-dimensional structure. You have a lot of accessory canals. So these are called as the lateral canals, furcation canal, depending upon where it is present in the root portion. Understood? So all these will again exit the root through foramen called as an accessory foramen. So what is this apical delta? So you can see there is a triangular portion. You all know what is a delta, right? So delta is nothing but a triangular portion that is formed between your main canal and your accessory canal. So this is a common basic knowledge about your pulp cavity anatomy. Okay, talking about the tooth apex. So basically we have three important landmarks. One is minor apical diameter, which is otherwise called as apical constriction. Don't get confused. Your minor apical diameter is apical constriction, whereas your major apical diameter is your apical foramen. The third one is your cemento-dentinal junction. Okay, so out of all these three, your cemento-dentinal junction is a histological landmark. So your main important clinical landmarks are apical constriction and apical foramen. So what is this? Basically, apical constriction is nothing but it's a very important landmark till which your BMP, your obturation, everything should terminate. It should not go beyond that. Okay, that is apical constriction. Whereas your apical foramen is your major opening of the root canal to the external surface of the root. Okay, so in the X-ray, when you are doing, what you see is your radiographic apex. It is not actually your anatomic apex. The anatomic apex is something which you will see only after you extract the teeth. So in your X-ray, the tooth will appear straight, but when you extract and see, you can see the tooth apex is somewhere else. Okay, that's why they are telling always your apical foramen will not coincide with your tooth apex. There will be always an offset of some 2 to 3%. Okay, so these are three important landmarks. Your apical constriction, apical foramen is very important, and all your BMP observation will terminate at your apical constriction. Okay, then root canal configuration. There are many classification for it, but veins and vertices is very important. According to veins, there are four classification. So just remember this diagram, and there is one shortcut which I used to like I used when I studied. So 1 1 2 1. Just remember the first two one. The next two classification, you just replace the number. If there is one, you put it as two. Okay, for example, the type 1 is 1 1, which means it starts as a one canal in the chamber and it will exit as a one canal only. 2 1 means it starts as a two canals from the chamber, enters the radicular portion, and in the radicular portion it will join and exit as 1. The type 3 and type 4. So if type 1 was 1 1, replace 1 1 with, okay, 1 with 2. Again 1 with 2, so it's 2 2. So if type 2 is 2 1, your type 4 will be just ulta of type 2. So 2 1 means your type 4 will be 1 2. Understood? So the same concept. Okay, 2 2 means it starts as two canals and ends as two canals. 1 2 means it starts as one canal but exit as two canals. The same concept you use it for vertex also. In vertex you have 8 types. Just remember first 3 types. Type 1 is 1 1, type 2 is 2 1, type 3 is 1 2 1. And the next 3 types will be just ulta of the previous one. Type 4 is ulta of type 1. So it is 2 2. Type 5 is ulta of type 2. Type 6 is ulta of type 3. And type 7 and type 8 you can write. Okay, this is how I used to remember. Then isthmus. What is isthmus? Isthmus is nothing but when there is two or more canals, there will be always a small communication between the two canals, right? That is isthmus. Isthmus is nothing but a narrow ribbon-shaped communication between two canals. So it is of 5 types given by Kim et al. It's very important classification. Type 1 is nothing but your short, a faint communication. Okay. Type 2 is a definite, complete communication. Type 3 is a small, complete or incomplete type of communication between the two root canals. Type 4 is a communication between multiple canals, whereas type 5 is no communication. The same classification is given in a Grossman and is also in the Cohen. It's a very important classification. And this is C-shaped canal. So what is C-shaped canal? Usually in mandibular molars we have 3 canals, right? You have mesiobuccal, mesiolingual and distal. So what happens now in mandibular second molar particularly? It is an important viva question. C-shaped canal is highly found in mandibular second molar, where all your 3 canals will be combined in a single C-shaped. It's like a half degree semicircle, 180 degree. Okay, it will be looking like this only. The morphology of the axis cavity for a C-shaped canal will look like this. And again in this we have 3 types given by Melton: type 1, type 2 and type 3. So this is your type 1 and type 2 and your type 3. So type 1 is a complete C-shaped canal, whereas in type 2 it is a semicolon shape, where mesiobuccal and mesiolingual will be a half portion of semicolon and distal will be separate, and in type 3 it will be all 3 separate canals. Okay. So now this is very important. Your Crasher and Ranko are the two important pioneers who gave the different laws for orifice location. It's a very important short note. So first one is the law of centrality. Always remember in all these law, cemento-enamel junction. Don't confuse with cemento-dentinal junction. Cemento-enamel junction is very, very important. It's an important landmark for locating your orifices. So first is law of centrality. They are telling your root canal orifices will always exactly occur at center of the tooth at the level of CEJ. Okay. The black line which you see now, that's the center of your tooth, and this exactly at the level of CEJ you will be having your orifices also. Now, law of concentricity. What is concentricity? See, when you do an axis cavity, always remember your walls of the axis cavity will be always parallel to your external surface of the tooth. If it is in a rhomboidal shape, your axis cavity shape will also be rhomboidal. Okay. What is law of CEJ? Your law of CEJ is nothing but your distance between your walls of axis cavity and the external surface of the tooth. It will be equidistant. For example, if it is here 3 mm, here also it will be 3 mm. Here also it will be 3 mm. So, and there it will be exactly at the level of CEJ. So, in this level, you can guarantee, you can tell that your root canal orifices will be located there only. Okay. Law of color change, always look at the floor. The floor will be darker than the walls. And symmetry. So there will be 2 laws of symmetry, first law and second law. So basically this is not applicable for your maxillary molar, except that all the tooth it will have this law of symmetry. So when you draw a line in the mesodistal direction, always your root canal orifices will be equidistant on both sides to this line. And second law of symmetry is that your root canal orifice will be exactly perpendicular to this line drawn in the mesodistal direction, and this is applicable to all the teeth except maxillary molars. And orifice location, again it's first, second and third law. The first law is nothing but your root canal orifices will be exactly located at the junction of the wall and the floor. Okay. And second law of orifice is also the same. It will be exactly located at this floor. So what is called as a mouse hole effect? It's a very important viva question. So basically always remember your root canal orifices should be located exactly completely on the floor. It should not extend onto the wall. If it's extending onto the wall, it looks like this only. A part is here, a part is on the floor. It's called a mouse hole effect. This is wrong. And third law of orifice location is that supposing if you are located 3 orifices and you are not able to locate the fourth one, you just need to follow this developmental grooves. Then if you are following it, you'll be able to reach the final orifice. Okay. Okay, these are some other aids which we usually use when we are not able to locate the root canal orifices. The first one is your dentinal map. So basically dentinal map is nothing but these darker lines which you see on the floor is called as a dentinal map. Sometimes if you are not able to follow any, locate any one canal, we just trace this dentinal map. Okay, it will go and lead us to that missing canal orifice. So you just need to be very sure. It will be located exactly on the floor. Once you cut the floor, you will not be able to visualize this dentinal map. Okay, excuse me. The next one is your red line test. Sometimes what we do now in case of a vital pulp, if you're doing an intentional RCT and you're not able to locate the orifice, we put a irrigant, hypochlorite irrigant, and you can see this dissolved pulp tissue. It will get connected by this some red line. So if you just follow this red lines, you'll be able to locate the one more orifice. Okay. What is white line test? So white line test is this image. So basically in a necrotic pulp tissue, sometimes if you or any calcified tissue, if you're not able to locate the orifice, what we do now, we use this ultrasonic tips. So when you use this ultrasonic tip, there will be a lot of debris which are produced. So this will go and connect all this orifice. So this is seen as a white line. Okay. Next one is a fast break. This is an important MCQ that can be asked. So basically, if you're looking at an X-ray, especially in premolars where these bifurcations and trifurcations are more common, your root canal suddenly disappears, and you will not be able to visualize that root canal in the X-ray. Okay, so this is called as a fast break. If you're coming across this kind of radiograph, it means your root canal is actually bifurcating into two or three root canals, or two or three accessory canals. This is called as a fast break. Suddenly, a break of a root canal appears. Okay. So with this we complete our anatomy of pulp cavity.